Good morning, doctors. Please welcome Dr. Ramchandra from National Tuberculosis Institute, Bangalore, head of the Human Resource Development, and who is extensively involved in tuberculosis control, teaching medical personnel in how to implement revised National Tuberculosis Control Program. He's going to talk on diagnosis of tuberculosis, and in the second lecture he will be talking on treatment of tuberculosis as per the new guidelines. Please welcome Dr. Ravichandra.
Diagnosis of TB. So this is an important topic because there are new developments. There is a revision of the technical and operational guidelines with introduction of newer methods of diagnosis and policy changes in our country and the whole world. Before going to the details, let us understand the concept of latent TB, that is infection and disease. Infection is the patient is infected but he will not be symptomatic and he will not have any signs. That is latent TB or the infection, and the patient who is having signs and symptoms of the disease is suffering from TB disease. So 1/3 of the world's population is infected with TB. That means there is every chance that the 1/3 of the world's population can break down to disease in their lifetime. For this, the contribution of India is around 40%, and 1/4 of all TB cases are in India. And there are many cases, that means around 3 million cases are missing in the world. That means we do not know the diagnosis and what is the type of treatment that the 3 million TB cases are receiving in the whole world. For this 3 million, the contribution of India is around 1 million. Out of all the infected patients, 10% will progress to disease in their lifetime. If they are dually infected with TB and HIV, there is a chance that around 10% will progress to disease every year. 1/3 of all the HIV deaths are because of TB. By treating TB in a HIV case, we will be able to prevent 1/3 of all the HIV deaths. Hence, there is a need to promptly diagnose and complete treatment in case of HIV TB. When infected patient presents with signs and or symptoms, he or she will be investigated as presumptive TB. So this can happen to 5% within the first 2 years of infection, and rest of the 5% will progress to disease any time in their lifetime. Definitions of presumptive TB. Presumptive pulmonary TB refers to a person with any of the symptoms and signs suggestive of TB, including cough of more than 2 weeks, hemoptysis, fever of more than 2 weeks, significant weight loss, any abnormality in the chest X-ray. In addition, contacts of microbiologically confirmed TB patients, PLHIV, that is people living with HIV, diabetics, malnourished, cancer patients, patients on immunosuppressants or steroids should be regularly screened for signs and symptoms of TB. Here, any abnormality in the chest X-ray is considered as one of the reasons for considering the patient as presumptive TB. It is not the suggestive TB lesion in the chest X-ray. The reason is there is an interesting study by International Union Against TB and lung disease. They selected around 1,100 X-ray films of the patients who were smear positive, around 200 patients. Previously treated patients were around 400. Minimal findings in the chest X-ray was 100. That means they don't require referral or follow-up. Non-TB lung disease were 100. Normal patients were 300. These 1,100 X-ray films were given to 90 experienced radiologists and chest physicians from 9 countries. The questions were asked, is the film abnormal, cavity present, abnormality in the lung, probably tuberculosis, is there any calcification, is it a non-calcified abnormality, probably tuberculosis, abnormality in the lymph nodes, is there any need for medical action? For these questions, if the X-ray is a very good diagnostic tool, then we would have expected all of them will have an uniform answer, at least majority of the experts. But the results are really shocking. Very high disagreement is there in almost all the questions. Is the film abnormal or normal? There is a 34% disagreement. Whether there is cavity present, 28% disagreement. Is there any abnormality in the lung? Probably tuberculosis. 45% there is a disagreement. Calcification present, 42% disagreement. Non-calcified abnormality, 37% disagreement. That means 37% of probably tuberculosis with a non-calcified abnormality, we will not have a firm answer. Is there any abnormality in the lymph nodes? 60% disagreement. Need for medical action, 31% disagree. Microscopist's job is very simple. If they spot a pink rod in a Zeal-Nielsen stain, it is very easy for them. 99% without any doubt, the microscopist will say that it is TB. Their disagreement is very less. If we consider the highest level of disagreement between the microscopists, it will be less than the lowest level of disagreement between the readers of radiographs. So radiograph reading, they'll have a very high disagreement. So further evidence, if there are 100 cases who are smear positive, out of them 17 will have non-TB abnormality in the chest X-ray. If we consider upper zone as suggestive lesion and with that X-ray lesion we want to diagnose TB, 17% smear positive cases will be missed. Overall, 24% smear positive patients, the X-ray will be opined as not requiring clinical action for TB. So 24% will also be missed. Atypical presentations of TB in PLHIV and children further reduces the reliability of chest X-ray for diagnosis of TB. Poor specificity of chest X-ray is proved by two other studies. The IUATLD study says that among the field conditions, the ratio of smear positive patients to smear negative patients diagnosed based on the X-ray requiring ATT is 1:5. Ideally, this should be 1:1. That means 4 patients are unnecessarily diagnosed as clinically requiring TB based on X-rays. This is overdiagnosis. NTA study says 2/3 of the patients diagnosed on the basis of chest X-ray were false positive for TB. So all these 2/3 of patients will be receiving ATT though they are not suffering from TB. So conclusion is many diseases mimic TB. Just because there is a lesion in the X-ray which is suggestive of TB, we should not conclude that the patient is suffering from TB. We have to investigate microbiologically because the upper zone is a favorite zone for even Klebsiella pneumonia, Staph aureus also. So many diseases they mimic TB. And TB can take any radiographic picture. There is no typical lesion which is suggestive of TB. So any abnormality in the chest X-ray should prompt us to think that we should rule out TB, then go for the other diagnosis. TB cannot be diagnosed by chest X-ray alone because though there is a very high sensitivity, there is a very poor specificity. This is a good screening tool. Further examination like bacteriology required for firm diagnosis. Definitions of presumptive TB. Continued. Presumptive extrapulmonary TB refers to the presence of organ-specific symptoms and signs like swelling of lymph nodes, pain and swelling in the joints, neck stiffness, disorientation, etc. and or constitutional symptoms like significant weight loss, persistent fever for more than 2 weeks. Night sweats are considered when there is a drenching sweats. So we have to rule out many a times there can be other differential diagnosis if there is a drenching sweats. So it can be menopausal, it can be a heart attack, it can be hypoglycemia, hyperthyroidism. So many other things has to be considered. So when all other symptoms are pointing towards TB, one should consider TB and rule out by the necessary investigations. Presumptive pediatric TB refers to children with persistent fever and or cough for more than 2 weeks, loss of weight or no weight gain, and or history of contact with infectious TB case. History of unexplained weight loss or no weight gain in the past 3 months. Loss of weight is defined as loss of more than 5% of body weight as compared to the highest weight record in the last 3 months. History of contact with infectious TB case is an important thing. There is no need that the patient is having any symptom. Just if the history says that the patient is in contact with an infectious TB case, the child has to be subjected for investigations to rule out TB. In a symptomatic child, contact with a person with any form of active TB within the last 2 years may be very significant. Definitions of presumptive TB. For the drug-resistant TB, presumptive DRTB refers to those patients who have failed treatment with first-line drugs. Failure, by definition, says that the patient is sputum positive after completion of 5 months of complete treatment. TB patients who are found positive on any follow-up smear examination during treatment with first-line drugs. Previously treated TB cases, TB patient with HIV co-infection at the time of diagnosis itself, pediatric TB non-responders, TB patients who are contacts of MDR TB or rifampicin resistance. That means a patient who gives history that one of the close contacts or household contacts is a patient of MDR TB, then he will become a suspect of drug resistant TB. What are the diagnostic tools? Tools for microbiological confirmation of TB. All efforts should be undertaken for microbiologically confirming the diagnosis in presumptive TB patients. Under RNTCP, acceptable methods for microbiological confirmation are sputum smear microscopy for acid-fast bacilli, Zeal-Nielsen staining, fluorescent staining, culture solid Lewensdin-Jensen media, automated liquid culture system, Bactec MJIT 960 Bactelert. For India, we have considered MJIT 960 as the method of choice uniformly across the country. Rapid molecular diagnostic testing, line probe assay for NTB complex and detection of rifampicin and INH resistance. Shortly, this will be extended for the other drugs and second-line drugs also. Nucleic acid amplification test, that is NOT test, or expert MTB RIF testing using gene expert system, or cartridge based nucleic acid amplification test, otherwise called as CBNAAT. Quality assured sputum smear microscopy, Zn, Zil-Nielsen or acid-fast staining. The requirement is around 10,000 acid-fast bacilli should be there per ml for the detection under this testing. Sensitivity of this test is 50%. Light emitting diode fluorescent microscopy. Fluorescent microscopy, staining with fluorescent dyes, more sensitive than Zn, around 10%. Union study says it is around 20% more than the Zn staining. Similar specificity, can read at lower magnification, that means it is quicker. Conventional fluorescent microscopy, it is costly. There is a requirement of dark room, limited lamp life, health hazards of mercury vapor lamp. Whereas the newly introduced LED technology, it is less expensive, light source, dark room not required, requires less power, able to run on batteries, longer life of bulbs, no toxic products if broken. This can perform in remote villages where there is no electricity using the solar lamps also. This is the conventional way of growing the bacilli, the solid culture and DST method. It is sensitive. It is actually the gold standard for the growth of the bacilli. Requires 10 to 100 bacilli per ml. Conventional is the LJ. There is a other method like 7H11 agar, etc. 2 to 8 weeks for detection of TB. DST is set up after identification of the test. 8 to 12 weeks for DST. It is time tested, robust and gold standard. Liquid culture and DST. This is automated MJIT 960 system consists of 7 ml of middle group 7H9 broth with an oxygen sensitive dye at the bottom of the tube, which fluoresces on depletion of the oxygen on the growth of microorganism. Positivity occurs from 4 to 21 days. Maximum usually by 14 days positivity will be seen. More reliable system for DST than LJ. So liquid culture is more reliable. Now of course for DST, liquid system has become gold standard. Earliest culture DST possible from 21 to 28 days. To say that it is culture negative, earliest is 28 days, but usually it will be declared by 42 days. It is expensive, higher contamination rate, need for negative pressure environment, proprietary item, so it will be usually costly. Molecular methods based on polymerase chain reaction and its modifications. Multiplication is based on genetic material, either chromosomal DNA or ribosomal RNA. When all ingredients are present in the reaction tube with target DNA, specific primers that bind exclusively to Mycobacterium TB sequences. PCR makes millions of identical copies of a specific DNA sequence, which may be gene, part of gene, a stretch of nucleotide sequences. Main advantage, it is faster and results are available within 24 to 48 hours. Newer tests are even faster. They are 60 to 90 minutes. You will have the diagnosis of TB as well as whether there is drug resistance. Line probe assay, commercially available assays are Inolipa Rifa TB kit and genotype MTB DR plus assay. Actually the second one is the one which we are using it in India. The rifampicin resistance in smear positive specimen is sensitivity is more than 95%, specificity is 98%. If it is a culture isolate, the sensitivity further increases to 98% and specificity 99%. INH resistance, smear positive specimen 70 to 80% and 98% specific. Culture isolate 98% sensitive and 99% specific. So this is CBNAAT. It is a game changer. Single-use disposable cartridge containing all necessary elements, automated sample preparation, amplification and detection. Provides results from unprocessed sputum samples, digital readouts within 2 hours. Opportunity for rapid diagnosis of TB. Limit of detection of 133 colony forming units per ml sputum. Sensitivity for PTB in adults is 88%, 98% for smear positive TB, 68% for smear negative TB, 79% in case of HIV positive, 66% in children. Specificity is equal to 98%. Rifampicin sensitive resistance through RPO-B gene, sensitivity is 95%, specificity is 98%. Minimal specimen handling and biosafety requirements. Technicians are trained in 2 to 3 hours. Inbuilt quality control. The quality control is done online every year. Expert MTB RIF Ultra is even more helpful. The requirement is 10 to 100 colony forming units per ml. So current RNTCP policy is diagnosis of rifampicin resistance in presumptive MDR TB cases. So prioritize CBNAAT to detect MTB in presumptive TB cases among people living with HIV/AIDS, pediatric cases and extra-pulmonary TB cases. So these are the patients who are offered CBNAAT at first instance, that is those who are suffering from HIV and they are symptomatic, so they should be investigated. Then the best test that should be offered first is CBNAAT. In case of pediatric cases, pediatric TB suspects or presumptive pediatric TB cases, presumptive extra-pulmonary TB cases, we should offer CBNAAT. The diagnosis of TB is always by CBNAAT. The algorithm for diagnosis in CBNAAT is, if CBNAAT result says MTB present and RIF resistance detected, then we should ask for the history of previous treatment. If there is a history of previous treatment, then we can be confident that there is a chance that this patient, this is not just chance, it is a diagnosis of DRTB, and we should refer these patients to DRTB center. If the patient is not giving any history of previous treatment, then there is a need to confirm it by repeating CBNAAT. As there is no history of previous treatment, the chances of patient suffering from rifampicin resistance is remote, so there is a need to confirm. If the repeat test says again rifampicin resistance, then we can confidently refer these patients to DRTB center. If there is a disagreement, that means the second test says it is rifampicin sensitive, then there is a need to refer these patients for liquid culture or LPA. So as per the result of this liquid culture or LPA, the treatment is decided. If the MTB is detected and rifampicin is sensitive, then in both the instances, whether the patient is having a history of previous treatment or if there is no history of previous treatment and the patient is new, both of them, they should be initiated on the treatment appropriate to the history. Like if the patient is a new patient, start with the new TB treatment, and if the patient gives history, then you start with the PT-TB patient treatment. MTB detected and rifampicin resistance is indeterminate or invalid. Resend fresh sample because there is a chance that the sample has the problem. So again, if it is indeterminate, then fresh sample has to be sent for culture DST. If the MTB not detected, rule out other differential diagnosis. If there is an error or there is no result, then repeat test on same sample if available. That means if there is an error or if there is no result, then the chances are that there is a problem with the cartridge or the machine itself. So if the test is repeated, there is a chance that you will get the better result. If it is invalid result, then repeat test on a second sample. What is the dependability of CBNAAT in non-respiratory specimens, that is extrapulmonary specimens? Specimen type, if it is lymph node biopsy, 93% sensitive. Lymph node FNAC, 96% sensitive. Tissues all types, 88% sensitive. CSF, 85% sensitive. Pleural fluid, 34%. Other fluid samples, pericardial, ascitic, synovial, 67%. Gastric aspirate, it is 78%. These percentages are calculated as compared to liquid culture as the reference standard. So in all the cases, specificity is 98%, whereas in gastric aspirate it is a little more, that is 99%. A positive test provides useful confirmation so that ATT can be started promptly. A negative test doesn't always rule out TB. Extrapulmonary samples should be sent in normal saline for CBNAAT. This should be remembered in all the clinical settings. If a surgeon removes the specimen and you are planning to rule out TB, best is half of the specimen can be sent for histopathology in whatever the way you want, but the other half we should remember to put it in normal saline and send it for CBNAAT site. So also please note, for the pleural fluid, the sensitivity is just 34%. So for the pleural fluid, we should depend on the traditional way of diagnosis. If the availability of CBNAAT is there near to your center, it can be utilized if there is a doubt. The diagnostic algorithm, which is altogether a new one, the diagnostic algorithm for the diagnosis of pulmonary TB is presumptive TB patient. If he is already PL-HIV, that means a person who is also suffering from HIV, then we know that these patients should be offered CBNAAT at first as the first diagnostic tool. If the patient is non-HIV, then smear examination can be done. Chest X-ray, if available, can also be done. If the smear examination says it is smear positive, then X-ray also has a lesion, then the diagnosis is microbiologically confirmed TB. If the smear is positive, but chest X-ray there is no lesion, then also it is microbiologically positive. Smear is negative, but chest X-ray there is a lesion, send the patient specimen or sputum specimen for CBNAAT. The smear is negative or not available, and chest X-ray either there is a lesion or not available. So there is a very high clinical suspicion, then also we can send the sputum sample to CBNAAT. So in addition to all these, if there is a PMDT criteria which suggests that there is a need for MDR diagnosis, or in those areas where there is a very high MDR cases, like in new cases, if the incidence of MDR is more than 5%, or among the previously treated patients, if the MDR rate is more than 20%, then one can offer CBNAAT at the start. So CBNAAT, if MTB is detected, rifampicin sensitive, microbiologically confirmed TB. Indeterminate, repeat CBNAAT on second sample. Indeterminate on second sample, collect fresh sample for liquid culture or LPA. If resistant, the same as we have already discussed in the algorithm for CBNAAT diagnosis. MTB not detected or CBNAAT result not available, consider alternative diagnosis and refer to specialists. So if the specialist says, so it is still TB, it will become clinically diagnosed TB. If the opinion is it is not TB, then alternative diagnosis has to be made. So all the presumptive TB cases should be offered. Compulsorily, the offer is HIV after counseling and testing. However, diagnostic work for TB must not be delayed. It is compulsory for the physician to offer the HIV test. Patient may not go or may go. He is free to do so. So this diagnostic algorithm will be available and it should be applicable wherever there is a facility for CBNAAT. However, if CBNAAT is not available, the available method of diagnosis can be used. But the important thing that has changed is we are no more diagnosing the TB patients as smear positive or smear negative. Instead, we are saying microbiologically confirmed and clinically diagnosed TB. Thank you very much.